thanks everybody for coming today. This is going to be a presentation around the implementation of bedside ordering systems. So if that's not what you're expecting to hear, the exits are over there. So we'll get started. I'm Mark Edell. I'm the Managing Director of Synbiotix. I've been with the company for about 6 years. And I have a history in NHS catering. I've worked for Appetito, I've worked for Hobart, so I've worked for a number of other NHS catering providers as a catering manager and kind of got a lot of experience inside that industry. And in about 2019, Synbiotix won the contract to supply the National Catering Information System to Scotland, and then shortly followed by getting the Framework Award for NHS Wales. And in a really short space of time, we were trying to mobilise 2 countries' worth of digital catering information solutions. And I just wanted to share a little bit of what that experience was like, dispel some of the myths, understand some of the challenges, give a bit of feedback to anybody going into that process, because of what's going on now with the NHS standards and the food review and everybody getting on board with digital catering and trying to implement electronic meal ordering systems and things like that, that there's things that I would have loved to have known 5 years ago when we were going in this, and things that we would have liked to have shared with the boards and trusts that we were working with ahead of time. So hopefully this presentation is going to bring some of that stuff to life, and anybody that's not quite on that journey or moving into that journey will be able to take some of this information and think, well, maybe I need to think about how I'm going to do this. Take a little bit more time, don't rush into it, just based on the information provided today. So it's by no ways going to be a sales pitch at all. It's just going to be anybody, whatever vendor you choose to go with, think about these things before you do it, because there's some things out there that I think have been overplayed, and we'll cover them on the presentation. I was supposed to be joined today by Rhiannon Facey Richards from Cumtaf Health Board, but sadly her little boy wasn't well today. So there's some slides in here about what's going on at Cumtaf, but I won't be able to speak exactly as Rhiannon was going to speak, but I was there on the journey with her and hopefully can do her justice around her journey with Synbiotix. But it would have been nicer her telling the story rather than me telling the story, but we'll have to just kind of work with that. So implementing EMO. Why have we got any business as Synbiotix talking to you today about implementing EMOs? Well, as I said, in about 2019, we won the catering contract to supply all hospitals in Scotland, and we were on the framework for Wales. But the company's been around since about 2005, and we started off as a clinical audit platform, and then we started getting into cleaning audits, and then we got into catering management systems. But the principles that underlie the building of those systems are exactly the same, really. It's all about data management, it's all about location management, and then training the users to be able to operate those systems. So we've been at this since about 2005, and you can see on there just some of the sites that we're looking for. And if I just snip to the next slide, what we're going to cover is the implementation implementation of the system to the patient administration system. It's been pitched along a lot of lines as to be the sort of best thing that you could do, and it really helps the system. And there are some benefits to it, but we'll kind of look at what some of the benefits are and what some of the challenges are. So just some of the people that we're working with. So why have we got any business talking about EMO at all? So here's some of the partners that we're working with. HCA Private Healthcare in Central London. We've recently got the contract for Sheffield Teaching. Lots of boards up and down the country in Scotland and Wales and all over the place. And we estimate that at the moment we're covering about 25% of the NHS beds, either with one of our cleaning systems, watering systems, or catering systems. And that's kind of what I want to talk to you about today. All of the experience that we've gained over that piece of rollout. So the last 5 years of rolling out this system in those places has not been easy. There's been a huge amount of challenges, and some of them have been technical, and we own some of those challenges, and around data management and how the systems are being implemented. But a lot of them are things that could have been mitigated early doors, and that's kind of what I want to explore with you guys today. So the first thing anyone's going to need to go through is getting started putting a business case together, and then it's going to be understanding the data. And this is where a big challenge comes up, is that a lot of boards and trusts at a senior level will purchase a system, and then they'll hand this down to one of the catering managers or the stores managers and say, right, now crack on and implement that. But that guy probably hasn't got the IT literacy to be able to do the project. They certainly haven't got project management skills, and the data management skills that you need to build a catering information system are not what a catering manager's bread and butter. I don't get out of bed in the morning looking at spreadsheets and trying to understand how data moves about the system. So there are things to think about there around understanding the data, and I'll pull a little bit apart on that. Project management support is absolutely critical to getting any project up and running. Don't think that it's going to just happen by itself. It does need to have project management support from the IT team, from someone inside the catering department, or from someone from the facilities department. So get a project manager who's assigned to this, either contractor or someone from inside the trust and board. The administration was the piece that Rhiannon was going to talk about. Don't underestimate the amount of administrative time that needs to go into maintaining the system, even once it's been put in. And this is one of the big failings that we had when we tried to roll this out on a national basis, was that it had been purchased on a national basis, but no one was really appraised of what local resources were going to be needed to maintain the system. And there's some slides in here from Rhiannon that talks about how much admin resource at her CPU she uses in terms of whole-time equivalents to keep that up and running, and all of the data touch points that she has to manage. And then integrations, pros and cons to the PAS system, and then some stuff around the technical side of that integration. So getting started, everybody has to start with a business case, and normally those business cases will be looking at pure ROI. So if I put this system in, it's going to cost me 15, 20 grand a year, depending on the size of the trust and board. How long is it going to be before I get my money back on that? And that's fine, and the systems will save you money, but they will only save you money if they're implemented properly. So again, you get a lot of pushback. Well, we've put this system in and we're 12 months down the line, and we've not got the ROI out of it. Well, ROI only comes from the data in the system, and then using that data to manage your service differently. The system itself doesn't give you an ROI. It's about understanding what the outputs from that system are. Improve staff efficiency, removable paper, there's some good things there that a system can do. But what we try and do around the business case is to look at some more softer metrics, so things around improved patient outcomes, improved nutrition, reduction of risk, because those things are not directly linked to costs, but there's still massive benefits in terms of clinical outcomes, and they make a more sticky business plan, because it's not just on, in 6 months' time we're going to get our money back out of this, because what happens in 6 months' time if various things didn't happen and then you didn't get that return on investment. Statutory compliance is obviously a big thing, so how does implementing that system get you compliant with the national food standards and things like that? So, and then staff well-being, because if people are taking paper and it's shooting all over the hospital walls, it's one person's job to sit in a room and collate menu sheets onto what a digital system could do in 10 seconds. It really does improve that staff well-being. So the point being, just not to focus the whole thing around cost savings, but to do the thing around a more holistic approach to what a digital catering information system can bring. Project management, so I kind of touched on this before. Most of our projects will fail because of a lack of project management experience within inside the board. We've got project managers inside our company, and I'm sure all of the other digital catering systems have got project managers inside their company, but project management skills within inside NHS trusts or boards is not always where it needs to be, and you might not get the time and resource that you need. So going into any project, really make sure that you've got a proper project manager, either from IT or from someone coming in externally who understands how to keep all those waypoints in check, how to keep the data coming in and manage those different stakeholders before going into the process. Because again, if you're looking to get out of an ROI, it's only going to deliver that if you've actually implemented it properly and spent the time ahead of time planning to get it done. So define the objectives, really understand the scope, get a proper timeline in place, and then understand the stakeholders. And I'll come on to talk about a little bit of who those stakeholders might be as we go through the presentation. But project management, I can't emphasise enough, is one of the key reasons why these projects fail, or lack of project management. Understanding the data. So obviously any catering information system has got a huge amount of data that sits behind it, from pack sizes, naming, mapping to local items. So you'll have a supplier catalogue that will call it one thing, and then your local item description might be something else. All of this stuff needs to be understood, and I've rolled this up on the next slide, and you will see quite how much data it comes up into. So as well as all of the items that you've got, that rolls up into recipes, who's going to be responsible for maintaining that? Because it can't just be the responsibility of the catering manager. They already had a job, and now that needs to be managed in a separate system. And what we've found, normally when we're implementing this, is there's an assumption that the data that you've got, that you're running off of today, is good data. When you actually lift the lid on it, what you'll find is it's not good data, and the naming conventions are different. It's called one thing here and one thing there. The pack sizes are different. The storeman just kind of guesses what the stock codes are going to be and things like that. And when we try and import it into the system, digital doesn't do nuance. It's black and white. It's a product code, it's a name that links to this system, it links to that system, and it takes a long time to really get that data where it needs to be. And it's something that, again, gets underestimated, because you kind of think, oh, I've got this system in place that we're currently using, or it's all kind of being managed because the storeman does it. But there's a lot of heavy lifting and manual intervention that these guys do to make sure that your current process is working. And when you try and digitize that with bad data, it's that old adage of bad in, bad out. You won't get the information out of the system that you think you're going to get, because it's just got bad data that's feeding in there. One shortcut that we try and do, or people try and do, is to cut and paste from previous systems, but all you're doing is then bringing over legacy issues into the new system. And whilst it's a huge amount of heavy lifting from the start to be able to manually input this data or manually clean up that data, honestly, it's time well spent early doors to get out of the system what you want to get out of the system. So just as an example here, it's a really simple recipe for for gravy, mixed herbs, lamb stock and browning. Well, the mixed herbs might come from 3 different suppliers. You've got supplier A, supplier B, supplier C. So already for one product, we've got 3 data lines. And then I can times that by the amount of different pack sizes that I've got. And then I've got to link that to the nutritional information. I've got to link that to the costing information. So once you start doing stuff like that, you end up with, it's something like 4,000 lines of data for one systems build. So a recent trust that we did, there was 1,452 unique items that they were buying in. From 600 recipes, it was 3,058 lines of data to be imported. And whilst that doesn't sound like a huge number, if you see that on a spreadsheet and try and understand it as a human looking at it, it's virtually impossible, and it takes a long time. So manually doing it from the start and really taking the time to invest in cleaning that data up is a big win when it comes to building the system. So what we try and do now, and this is how I would advocate that anybody tries to do it, start from the supplier data, get your catalogues from all of your wholesalers and all your butchers and everything else, get that supplier data locked down in the first instance, because that's what you need to put the product codes into the system for. And then you create local items from that supplier data. So what do I mean by that? Well, a local item might be your mixed herbs, and the mixed herbs is then linked to 3 different suppliers. So they might be called different things in different catalogues, French mixed herbs, or different mixed herb name, but in your local catalogue it's just called mixed herbs. So you take your supplier data and you consolidate it down to a local set of items, and then ensure that you're getting regular catalogue updates as well, because all of the big wholesalers and manufacturers now can send API data backwards and forwards with catalogue updates, D-lists and things like that. So if you're not getting that, it's a manual process to have to go through. Every time they do a new catalogue release, you've got to put it all into the system and start typing that in, and it's just a massive thing. And what happens is the data in your system then becomes out of date. And if you're using the digital catering information system properly, it should be the Bible for allergen and nutrition information. It should be the Bible for all your costing data. And the moment that it becomes out of date, there's a clinical risk there. And as soon as you're introducing clinical risk, it gets a whole big world of pain for everybody. So stick with the supplier catalogues. That's where the most up-to-date information is going to be, because that's what they're selling you every day. Ensure the allergen and nutrition information is kept up to date. Again, try and do that as digitally as possible as you can. Avoid spreadsheets, because there's such a lot of manual translation error that can possibly happen in spreadsheets. And over the last 5 years, some of the data we've been sent from various different manufacturers is safe from their perspective, but it's on a PDF. Now someone's got to read that PDF and understand what does may contain mean in this content. So at the bottom of the PDF statement is, this has been made in a factory that contains nuts. Well, as a catering manager or someone on site, how do I interpret that into what's going into the system? So I've been advocating this for a long time, which is a national data repository for the NHS, where anyone that wants to do business in the NHS agrees on the data format. That data format is then stored somewhere centrally, and Synbiotix, Dataset, any of those other suppliers can call that central repository. I think we're a long way off from that, but it's actually the safest way that we could all operate, because otherwise there is a lot of manual translation and updating of data and things like that in the system that introduces error and, again, clinical risk. I've just put at the bottom, it can take up to 6 weeks to get that data set in a decent format, depending on the starting point. Just want to touch on mental health and communities. So there's been, everybody should have a digital catering information system, and whilst it can produce some benefits in some areas. The biggest benefits are in the acutes, where you've got a larger bed count, you've got larger food wasters and things like that. When you start narrowing that down to a mental health site that's 300 beds, but it's over 20 different little units, and they've all got different menus, and it becomes really, really tricky to try and implement a digital catering information system. It's not to say that there's no benefits there, but there's certainly going to be a much lower possibility of getting an ROI out of a mental health site. So it's not going to be that you put this in and suddenly you're going to save a load of money. Those mental health sites have got a lot of different challenges around how food's used in those places. It's not just a functional thing, it's used for emotional reasons, it's used as kind of a release from the sort of mundane nature of being in the mental health wards. And the same is true of a community site. Is it worth really bringing in a digital information system when you've got a 7-bedded community site, when you can literally lean round the corner and say, Joan, what do you want for your tea today? And you can put that in. So there's for me, and I might be doing myself out of some business here, but actually I would seriously consider whether there's a huge benefit or benefit at all to putting it into some of the smaller community sites. And what we tend to get is, we're going to standardise our menu. Also, all of these communities are going to be running on the same menu. And I've been in this hospital catering game for a long time, and I've heard that so many times. No one ever really gets to standardised menus. They think they're going to, and then there's so many different nuances and things that are happening that it never really gets there. So don't set out with that as the ambition, because honestly, we've tried it, and mental health certainly, they're like, well, but they use it in a slightly different way there, so we need another 6 different menus that's going on. So this is where I was going to come on to just talk about Rhiannon's experience. So Cwmtaf is one of the biggest health boards in the UK. There's over 3,000 beds that they've got. And Rhiannon was a previous head of food technology for Dawn Meats, and she's got an MSc in food science. And it was a really positive step, actually, of the health board to recruit someone from outside the NHS to come in and look at catering information systems and the production processes that they've got at the CPU there from a manufacturing perspective, and not necessarily from an NHS catering perspective. And Rhiannon has been in the game for 20 years, and she's been all over. She was in Cardiff Metropolitan University in 2018, where she specialised in labels and the data that was going on to labels. So for me, as a systems owner, it's been amazing to work with her, because her knowledge outside of the NHS is just absolutely impeccable. And she was going to talk today just about some of the challenges of implementing the system, and what she understood from, say, she worked at Beyond Meats, one of the biggest meat manufacturers in the UK, how to try and then upskill her own catering staff in the NHS to start operating on those sort of industry standards that you'd get in the commercial world. So the project was launched in about 2020. And the first thing we did was we put the NCIS product, which is the National Catering Information System, into the CPU, and we started producing all of the food out of that CPU, and it produced into 3rds and 6th gastros, and they send that out to 13 different hospitals. They send it across Wales. It's not just inside their health board. And then to get the data into the CPU, they did a bedside ordering project. So every time a meal's ordered at any given hospital across the trust, it will then generate a replenishment order back to the CPU. So they're managing it really as well as I've ever seen a system being managed, full stock management at site and at the CPU. So every time a hospital picks and packs a 6-portion lasagna, it tells the CPU, this has been used in this site, we need to replenish that and send it out. And they use it really, really well. And they're just moving down the process of doing some clinical sign-off. But along that journey for the last 4 years, there's been some heavy bumps in the road, and Rhiannon was going to come and talk on about some of those things. So at the central production unit, it's a cook-chill or cook-freeze facility. It's been open since '99. They've got 40 staff in that unit, and 4 of those staff up in the office on a rotational basis are to support just Synbiotix stuff. So she's got 4 people who manage all of the supplier catalogues, who manage all of the item updates, who manage all of the recipes, all of the label printing. So she's blessed, really, with a lot of resource in that admin office at the CPU to keep that system up and running. But she will even say it's probably not enough, and whilst they're keeping the whole CPU thing up and running really, really well, all the data's flowing through the system, the labels are being printed, the allergen information is correct, which is what her responsibility as the CPU manager is. Sometimes it's falling down a little bit when we get out to the hospitals. So the CPU is producing all of the frozen meals that are going out there, but now at hospital level, we've got yogurts and sandwiches and fruit and other stuff that the hospitals are buying separately. That admin team at the CPU are not looking after. So there's an additional resource that she's asked to bring in to actually manage the data now at menu level and at hospital level. So now there's about 4 or 5 people who are just involved in the administration of the system. They honestly are one of the best users of the system that we've got, and the reason that they are is because of the administration resource that they've got available to them and the experience that they've got from that CPU. And the point really of this part of Rhiannon's presentation was just to sort of say to anybody going in there, don't underestimate the size of the administrative burden there is to put in a system. I'd love to tell you that you can get it, you can turn it on, all your data is flowing from catalogues, recipes are updated, and I can make it look like that in a demo all day long, and any one of us can who's trying to sell this system, but if you don't administer it, it's not going to work. It needs people dedicated to it. Smaller hospitals, it's probably a couple of days a week. When you get up to the big CPUs, then it is a lot more resource, but it needs to have dedicated resource looking at it. So here's just a list of some of the things that has to be put into there: the raw material information, supplier information, allergens, nutrition, recipe data, ingredients, allergen and amounts, process information, when's it coming in, orders, dates, times, all of that stuff needs to be updated into the system. And some of it you do once, you don't have to do it again. But we all know, as NHS caterers, it's a moving picture. Things change, menu changes, things are happening all the time, and it takes quite a lot of burden in order to do that. We have tried to do some stuff with national procurement teams to get a single source of the truth for cost information, nutrition information, and I'd love to say that we've done that, but it's just not that straightforward. They have NHS stores in Wales that often changing product codes, changing products that are coming in. NP in Scotland have got a similar issue where suppliers are changing non-contract products. So now you can go out, everything's contract is great, we've got all the allergen information, all the costs are there, lovely, but what do you do for non-con? So there's all of these things that need to be managed as an administration system. And then she's, as well as the 3 big districts, she's got 6 community hospitals that are sitting under there, and this is where she's had some challenges around keeping the menus up to date, and she needs an extra person to come in and help her manage that administration. She just talks on here and then again about the project management for implementation. Make sure you've got a project manager, overriding resource, menu compliance, but I won't speak in her stead, and I'll skip on to the rest of my slides because I can speak a bit more eloquently about what I was hoping to say. So part of the engagement process, and this is where a project manager will help as well, clinical partners. So best case scenario, whenever we do an implementation, is it's catering staff end to end, and every NHS catering manager would love to have their own housekeeper or person walking around at ward level taking those orders. But in the real world, that doesn't happen, and a lot of the time, it's catering will hand over that responsibility to the nursing partners or the clinical partners, and it's healthcare assistants or other people that are taking those orders, and clinical engagement is absolutely key to be able to do that. So we've only found that about 30% of the sites that we work with is catering staff end to end. It tends to be the contractor sites, to be honest with you, the ones that have got their own resource. The contractor manages that, their own staff. Typically, if it's an NHS in-house trust, it's not that often that it's catering staff end to end. And it does make a big difference. So in Scotland, they've had huge challenges engaging with those clinical staff and getting them to actually take the orders themselves. They just get told, we don't have time, there's not enough time, how are we going to do this? But they'll still fill in a piece of paper, or they'll still send paper all over the hospital. So getting that clinical engagement is absolutely imperative. And the one way that we've actually had some success with doing that is to actually brief the Director of Nursing. If you can get the Director of Nursing on board, what typically happens is they make a mandate to say everybody's going to be doing this, and whether you like it or not, this is what's going to have to happen today. And it's almost like a military operation that once that orders come from the top, all of the wards fall in line and everybody does it. But if you don't have that Director of Nursing buy-in, then it often falls down, because on the weekend there's no healthcare assistant to be able to take the orders, and then no one's taking orders, and then the whole system falls down and it all kind of becomes a bit mucky. The other thing that we do with clinical engagement as well is around the allocation of bed statuses to the individual patients. So not just relying on nutrition hydration boards or bed cards behind beds to say this patient's on a gluten-free or they're on an IDSI or whatever. You can digitise that process, but again it requires that the dietitians or the speech and language therapists are on board with digitising that process. I was at a site the other day and I saw the old nutrition hydration board with squiggles and wiggles and lines and all sorts of bits and bobs on there, and that was what they preferred apparently over actually having a digital auditable solution. I just think that the levels of patient safety that you can bring in with digitising that are astronomical compared to just having a board that no one knew when it was last updated, who updated it, who stuck the little sticker in the right place on there. And then now the housekeeper is supposed to use that information to go and safely take orders. It doesn't feel quite right, but there's a patient safety element to that clinical engagement that I think we should be thinking, again, holistically about, just coming back to that bit at the start. So this sort of brings me on to the integration to PAS and electronic patient records. Everybody has an idea about this being the best thing that you can do, that if you can integrate the digital bedside ordering system to PAS and EPR, it's going to yield huge amounts of benefits because real-time patient data, real-time allergen and nutrition information. And it's true, you can integrate the system to PAS and you can realise some of these benefits, and we've done it. But we've also been all the way through the process and got to the end and found that there isn't any allergen and nutrition data in PAS in the first place, and in fact it's kept somewhere else. So going into this is a process that should be considered way before, and not to make an assumption that integrating it to PAS is the best thing that you can do. Where we've had a lot of success is to do it incrementally, put the system in and then run the PAS integration as a separate project. There was a recent tender that came out that had PAS integration as a standard for it. And we sort of pushed back to them and said, well, it's fine, you can do that. Have you spoke to your PAS suppliers to say that they will integrate to any digital bedside ordering system? Because whilst it's part of a tender, and this happened in Scotland as well, all of that bedside ordering system was bid with integration as part of the cost of doing the whole project, but none of the health boards have actually taken it up because of the complexities of being able to do it. So we've had to then wind out some of that integration part of the expense of the contract, because there's no point in trying to do it if the PAS suppliers are not up for doing it. So some of the benefits obvious. The patients move, the meals move with the patient. If he was in bed 5, now he's in bed 7. Brilliant. If that happens before the meal's already been loaded into the oven or gone down the belt. So on the face of it, sounds amazing. Meals will follow the patient, brilliant. But they only do it if it's been happening within a really small window of order into actual delivery. And there's systems in place already for making sure that that doesn't happen. Empty beds and nil by mouths are updated, absolutely true, and you will get huge savings on that without people being able to order for empty beds, or just for Mrs. Davis because she's gone for surgery, she was on nil by mouth, but maybe will order a sandwich or whatever. The system will prevent you from doing that, and there are some quite big savings to be had from there. Allergen and diet status to the patient and not to the bed, fantastic, because if the patient then does move to another bed, the allergen and diet status is follow them. Must and diet flags can follow patients around the hospital as well. Real-time updates, so the tablets, when they're taking the orders, will be linked through to the PAS in real time. But if you look at the workflows for some of that, again, if the PAS has changed in the process of taking the orders, having the tablet update if you're on a ward that then doesn't have Wi-Fi connection can be big problems. So you have to think about the workflow as well as the fact that you could possibly do it. If the workflow doesn't support it, then there's other ways that you can manage that operationally. Removal of nutrition hydration boards. So I've just put an example one up there. So again, I just had that. We walked into the ward kitchen and I couldn't understand how anybody was intuiting from that board what they were supposed to be serving to their patients today. It was just all squiggles and numbers and it didn't make any sense. And it's completely auditable. So any changes on PAS, if there's a swallow assessment, Salt's done that, it will be auditable through a digital system that you don't get if you're just using it on an analogue. So some of the challenges, it's possible that there's multiple vendors. It doesn't follow that the PAS is a single source of the truth. You could have a separate PAS and EPR supplier. We've come across this recently where PAS was Cerner and the EPR was Nerve Centre, and not even those two systems didn't speak to each other. So understand the architecture of that PAS system, what's in the PAS system before you're doing it. Lack of support, so again, the will can be there from the facilities team, the will can be there from the digital bedside ordering team, but if the will is not there from the PAS provider to actually make that integration happen, it's not going to happen because they tend to be much bigger companies than the EPR, the EMO guys, and it's done at an ICS level where you have to talk to someone that you don't even know who they are, who's owning that system. So again, just think carefully about whether you're actually going to be able to do that. There's a huge amount of regulatory compliance linked to putting that patient data into the system. So if you're going to call the PAS, you have to do a lot of more governance check-in, patient name check-in, and you're going to be going into where patient records are held. So there's a huge amount of compliance that's needed to be, hoops to be jumped through. Again, it needs to be auditable, it needs to be accountable. If there are changes, you need to be able to document as the EMO supplier why you gave certain meals to certain patients. And data protection and security concerns obviously come into that as well. Technical complexity, so there's a huge amount of work that needs to be done, and it's all done in what they call HL7 messaging, and it's not an easy thing to be able to do, and most people don't have a HL7 data coder within inside their EMO team. So whilst it is possible, it's technically quite complicated to do, and the amount of data that's required to pass back between the two systems is quite intense as well, so it can put a big burden on the servers if you're using too much data. Data standardization, so the locations that are in the PAS need to link to the locations that are in the EMO. Who owns those locations? Who's responsible for updating it? If you've put a new bed into the PAS, how does it pull through to the EMO? Because now you're putting people in corridors because you have to. So how do you feed them if they're not in the PAS? So there's a load of technical information that needs to be passed through, and typically with catering, it's not a flat field. It's not that it doesn't change day to day. Everything's changing. It's so dynamic, and it is difficult to digitize it. It's not that the EMO providers are not trying, but everything's a moving field. And if you try and structure it too much, it removes some of the benefit of what we all got into catering for in the first place, which is being able to provide patient-centred care. It's like, okay, he wants this meal, let him have this meal. We'll worry about the other bits of it later. Or there's a patient in the corridor. Let's get him a sandwich. Sometimes trying to do too much with the digital side of things can remove some of that nuance and care providing that we're able to do as caterers. So information governance, everybody will have to do a DPIA, and you have to do these for all systems. If there's patient data into the EMO, that DPIA becomes a much more onerous piece of work to do. There's a load of hoops to jump to. Identifying if one's needed, describe the data processing, assess privacy risks. There's a whole world of this that each trust has a different form, which is quite annoying as well, because you could just have one standard NHS form, but that's not how it works at all. Everyone has their own DPIA form, and it's a different version of it with different data requirements and everything else. So just as an EMO provider, whenever we've done these for trusts, they just hand it over to us, but a lot of it is the facilities department's responsibility to fill in. So just take there's a bit of ownership there for completing those DPIAs. Don't just get it and hoy it over to the EMO provider, because a lot of it will be around how does the trust manage its own privacy policy, how does it manage its training requirements and things like that. There's also the DTAC, so Digital Technology Assessment Criteria, that needs to be completed. So all systems that are required to be into NHS sites need to have completed a DTAC. And that's part of that is linked to clinical safety, and I've had it pushed back to me to say that electronic bedside ordering systems really aren't linked to health systems, and it's not a clinical risk, but actually the moment you put allergen and nutrition information into a system, there is a clinical risk there for anybody that's going to be using that system to order meals, and therefore you do need to do something that's called DCB 129, and the DCB 129 is the clinical risk management standard for the NHS. And there's a part of that for the trust as well, which is DCB 160. And that says, certainly if you're going to link the system to the PAS, you shouldn't be linking the system to the PAS unless a hazard log's been produced and the clinical risk of that system has been assessed. And it's a huge undertaking, it's massive. There's a clinical risk register that needs to be made. There's a whole load of data flows that you need to understand. And you have to have a retained clinical risk officer inside the EMO provider to be able to do it. And our one is a pain in the backside, but she's a pain in the backside for the right reasons, because every piece of development that you want to do, any change that you want to make in the system has to reflect the clinical risk or understand the clinical risk before we're able to do that. And it slows everything that we do down. We can't be as responsive and reactive that we need to be. But if you're going to link the system to the PAS and you're going to be pulling patient data and you're going to be sending meals to them that you're saying this absolutely is safe, it's the right meal for that patient, all of that process needs to be audited, all of that process needs to be checked out. So there's a risk log, there's a hazard log, there's a whole world of things that the EMO providers need to go through in order to do that. So this just really speaks to that whole thing of, is PAS the right thing to do? Probably, it's great, But there's lots of things that need to happen in order to facilitate that happening. Certainly the production of the risk log and the hazard log, and making sure that the right meal has been taken for the right patient and provided to the right patient. And again, this is all auditable and publishable, and it comes under that DCB 129 thing. So what works well, and I'll just be summing up now. So certainly get a project manager. Without a project manager, it's going to be really tricky to implement the EMO. Establish links with IT early. IT are going to be absolutely imperative to making sure the project gets off the ground. Although most of these systems are cloud hosted and the burden on IT is really quite small, they still get very excited if you don't tell them, and then suddenly they're having to put tablets on MDMs and they get a bit upset about the whole thing. So engage with IT. I would ask for IT to assign a project manager, because then that kind of keeps it all tight, and the IT project managers are really good at understanding what their IT team need, and it feels like a bit of a pain in the backside again, but those project managers for IT will keep everybody straight. Don't underestimate the amount of admin resource required. It's not a straightforward process to firstly build the data set to implement, and then to maintain that system going forwards. Really think about whether or not you want to do a PAS link. Like, it's great, but it is hard work, and the maintenance of it's hard work, and there's a lot of hoops to jump through, certainly from a compliance perspective, to make sure that the systems are speaking to each other safely and that the meals are being sent up safely. Try not to use historic data when you're building the system. Starting from fresh is a much better thing to do, and I wish I'd understood that 5 years ago, because we tried to cut over a load of data, and all we've done is spent the last 5 years just trying to really make it right, and it would have been easier just to start from scratch. Get supplier catalogues from source, so everything should be built from the supplier catalogues, and then create those local items. If you remember the mixed herbs example, map that to your local items. Try and ensure the senior team member is driving the project and understand why it's being done. Again, a lot of people go in, we're going to put an EMO in and we're going to save loads of money. It's like, okay, but you'll only do that if you look at the data that's coming back from that EMO and then use that data to reduce wastage, to improve efficiency. The EMO itself won't do those things. It's a management tool that is used to make those things happen with inside the trust of the board. And help upscale with IT literacy. A lot of challenges we got in the early days, and it's getting better now, it's true to say, is that people weren't as literate with the IT as they should be. So they were then saying, oh, well, the system doesn't do this and the system doesn't do that, but it's because they weren't so au fait with the general operation of the system, and projects teams will help with that. But if you are recruiting for a role, make sure that IT literacy is part of that sort of understanding, and that they understand data and they understand how to use an EMO properly, or the benefits of digital systems, because historically a catering manager's job was to do catering. It wasn't to manage spreadsheets and manage data going backwards and forwards. So I'm going to just go there for any questions. I think I've got to my 5-minute warning as well, which is actually pretty good timing. So thank you.